So I'm Kylie. I'm the benefits manager at the consortium, so your health insurance. And we run a wellness program. And for this month, it is Mental Health Awareness Month, but it is also Skin Cancer Awareness Month. And luckily, we have Dr. Josephine McAllister on the line with us today as our guest presenter to talk about skin cancer prevention and what we can all be safe in the sun this summer. So I'm going to turn it over to her to go through her slide deck with you. If you have questions, feel free to put them in the chat, and we'll pause certain points during the presentation to have those read. Thank you so much.
Thank you, Kylie. Hi, everyone. I'm Dr. Josie McAllister, and I'm here from Dermatology Associates of Ithaca. I am very excited to be celebrating Skin Cancer Awareness Month by talking about skin cancer prevention for everyone. Really appreciate all of you being here over your lunch break. And as we're about to talk about, the noon hour is a great time to be sitting in the shade together. So without further ado, what is skin cancer? It's the uncontrolled growth of abnormal skin cells occurring after ultraviolet radiation from sunlight or tanning beds damages DNA in skin cells, triggering mutations that turn them malignant. The two main types of skin cancer include melanoma, the deadliest kind of skin cancer, and non-melanoma skin cancer, with squamous cell skin cancer and basal cell skin cancer the most common types. As you can see from this diagram, the skin is comprised of two layers, the epidermis, or the outer layer, and the dermis, the inner layer, where there are blood vessels and nerves through which cancer cells can travel and spread. Our goal is to find skin cancer early when it's still in the epidermis and be able to eradicate it at that early stage. Skin cancers are by far the most commonly found kind of cancer in the world. There are more than 13 million skin cancers diagnosed yearly, meaning they are one of every 3 cancers diagnosed. And in the US, more people are diagnosed with skin cancer every year than all other cancers combined, including breast, lung, prostate, etc. This means that 1 in 5 Americans will actually develop skin cancer by the age of 70, as ultraviolet exposure builds up over one's lifetime and the immune system's effectiveness diminishes. Even one blistering sunburn in childhood doubles the risk of developing melanoma later on. By 2025, melanoma is estimated to be the 5th most commonly diagnosed cancer for women and for men. Even in central New York, you can get skin cancer and melanoma. Our practice diagnoses a melanoma every week, and lots of times patients have no idea it's even on their skin. Because we have long winters, people think our sun exposure is not significant, but in fact, we actually receive 70% of the UV exposure that one would receive in San Diego. In New York State, melanoma is the 9th most common cancer of any type, with over 500 deaths yearly. And for adults aged 20 to 34 years, melanoma ranks among the top 4 most common cancers nationwide. Every year at Dermatology Associates of Ithaca, we treat thousands of precancers and hundreds of skin cancers, including over 50 melanomas yearly. And that's more than 1 new melanoma every week. The bad news is that a tan never fades. Approximately 25% of a person's lifetime sun exposure occurs before the age of 18 and accumulates over time, like filling up a glass that at a certain point tips the balance towards skin cancer. In addition to the skin cancer risk, UV exposure causes premature skin aging with as much as 90% of visible changes, including wrinkles, brown spots, and thickened leathery skin due to the sun. UV radiation also causes cataracts and other eye conditions that cost over $7 billion a year to treat, over twice what it costs to treat skin cancer, and suppresses the immune system's ability to defend against all cancers and all infections. The good news is that skin cancer can be treated early. Melanoma detected early has a 99% 5-year survival rate, and early treatment before invasion into lymph nodes, blood vessels, and organs can save lives, preserve functionality of vital structures, and is the most effective use of healthcare resources. We recommend performing skin self-exams as half of melanomas are actually detected by patients. They can present as new, changing color or size, or not healing for more than 2 months. And everyone with a history of sun exposure or family history of an atypical mold or skin cancer should receive a full exam at least once by a dermatology provider, if not already done. So nobody needs to come in with a large melanoma like this nodular melanoma on this patient's back. We'll talk later about the ABCDEs of melanoma. So with no further ado, let's meet some skin cancers face to face. Actinic keratoses, or AKs, are these pink, scaly, precancerous rough spots in sun-exposed areas, like the scalp and on the face and on the nose, that sometimes can be felt more than they can be seen. 10% of them progress to skin cancers, but we don't know which 10% it's going to be, so we treat them when we find them, either with liquid nitrogen, which is a cold, stingy spray, or a chemotherapy cream. If these progress, they can turn into a squamous cell skin cancer, SCC, which presents as a tender, pink, scaly, bleeding bump in sun-exposed skin. They're almost always curable if diagnosed and treated early, but if not, they can metastasize and become fatal. For every patient who comes in for a full skin check, we look at all of their skin with a handheld microscopy called dermoscopy. And here's a lovely dermoscopy photo of a squamous cell skin cancer up close. You really can see much more detail in including blood vessels. You can see this keratotic core, which, remember the photo that we looked at of the skin previously with the different levels. So the very top is the so-called dead layer. Sometimes those layers can pile up. If a skin cancer is growing very rapidly and you actually can get what looks kind of like a volcano on the skin. If you look at this ear, there's this bleeding bump. If you look here at the arm, there's this volcano with this keratin center and the top of the hand. And at this point, this one, you can see that it's a little bit thick, so it may even have gone into a nerve. It might be a little bit tender if pressed on. Basal cell skin cancers, on the other hand, are smooth and pearly. You can see this beautiful derm-like photo here and here. So they have this hot pink color, and they have these large blood vessels. That's one way that tumors grow in the body, is they're able to recruit blood vessels to themselves and divert nutrients to their own growth. BCCs are the most commonly occurring form of all cancers. They can be very sneaky and mimic different things. For example, here's a basal cell skin cancer mimicking a rash. The patient was diligently treating the rash with a cream from his outside physician. It wasn't getting better. Finally, they thought, let's send the patient to dermatology. Turns out it wasn't a rash. It was a basal cell skin cancer. Here's a barely perceptible bump on the tip of the nose. So oftentimes basal cell skin cancers can hide in normal anatomy. They love to hide in the corners of the eyes and corners of the nose and corners of the mouth. So we always look very carefully in those areas. And here's one on the chin, just looking like a divot. But the clue to the patient was that it was there for longer than 2 months and not healing. If it was an acne spot, it should be gone within a couple of weeks. And here's one on the scalp. It can be very difficult to find things in hidden areas. And we'll talk later about how, we think that we can see our own skin. Often patients will come in and they'll say, oh, I don't need you to look at all of my skin because there's nothing. But we can't see the top of our own head, right? And we're not able to see behind our own ears. So it really helps for someone to take a look at everything thoroughly, look through the scalp, look through the hair. Now, basal cell skin cancers, because they grow very slowly and they almost never spread beyond the original tumor site, although rarely they can. And I've seen this happen in some patients. Even if they're only locally invading into local structures, they can be very disfiguring. So for example, around the nose area, we need our nose, right? We need our nostrils, near the tear duct area. All of these are important structures to save as much as we can. So we always do recommend treating these. Or even if they just, are not near a vital structure, but there are blood vessels very close under the skin surface. So we've had patients leave a basal cell skin cancer growing for decades, which I don't recommend. And eventually it could go into a blood vessel and cause the patient to bleed to death. Or a patient in the nursing home, if they have a chronic non-healing growing skin cancer on their face, then anytime you have open skin, there can be a bacterial infection that goes in to that open skin, and their family members may not want to visit them anymore if they have this smelly, pussy open area. Obviously, we want to be very aware of the patient's entire health status and their social condition and what their preferences and their lifestyle is like and what they are able to tolerate in terms of diagnosis and treatment. So we always take all of that into consideration, figuring out what is the best treatment for each individual lesion in each individual patient. Most deadly of all is melanoma, which kills one person every hour in the United States. Its incidence has jumped over 200% in the past 3 decades. Daily use of SPF 15 sunscreen, including in the winter when ultraviolet radiation still comes through the clouds and through clear window glass in your office, can reduce melanoma risk by 50%. That's why I recommend for all of my patients to put that sunscreen on every day year round. They ask, what is the best sunscreen that you recommend? And I always say, the one you'll actually use. The ABCDE signs of melanoma include asymmetry, where one half doesn't match the other, irregular borders around the spot, different colors in the same lesion, diameter greater than 6 millimeters or the size of a pencil eraser, and evolution. Early detection can save a life. Patients, again, when they tell me they don't see anything bad on their skin, I remind them, well, you can only see 50% of your own skin. And anyone with fair skin or a history of sun exposure or indoor tanning or a family history of skin cancer or many moles can benefit from a full skin exam. Here's a picture of the handheld microscope called a dermoscopy that we use to carefully scan the patient's entire skin on full skin examination. And here's an image of a shave biopsy. If we see a lesion that's suspicious for skin cancer, we recommend taking a sample to send off to the lab to look at under the microscope so that we know 100% what the diagnosis is. You can't always tell just by looking at it what it is. And when we get the biopsy, we're able to tell what kind of cells are growing this tumor and how deep have they gone and what is the most appropriate treatment given all of the specifics that we see under the microscope. It always helps to have another set of eyes, as skin cancers and atypical moles can be sneaky. Patients often come to see us with other complaints like skin tags and acne, and it's only then that when we do the full skin exam that we find suspicious spots that they never knew they had. So here's a patient. He actually is a physician who came in with flaky spots on his face. And when we examined his entire body, we actually found this very dark, bigger than a pencil eraser sized brown spot on his thigh. When we see a suspected melanoma in the office, we typically will try to do a bedside surgery to take the whole thing out so we get the full depth. The depth of the lesion tells us how invasive it is and whether it needs further work, including lymph node biopsy or another deeper, wider surgery, for example. So we immediately remove this spot in the office, and the biopsy showed a deep melanoma. At that point, we worked with our plastic surgery colleagues to make sure that the lesion was adequately removed with large safety margins so it wouldn't come back, and also so that there could be lymph node biopsy. So it's very common for melanoma, if it spreads, to go into the lymph nodes that are near near the area of skin where it originates. So here on the leg, it would be the lymph nodes in the groin, for example. So what the plastic surgeon will do during a surgery for an invasive melanoma is they'll put in some dye, see where the dye drains to. It'll show them exactly which lymph nodes to sample. They'll look at those under the microscope. When they looked at this patient's lymph node under the microscope, they actually found leukemia. We had no idea that the patient had this until the lymph node biopsy was done. It showed a type called chronic lymphocytic leukemia. He was referred to oncology. He was started on treatment. And 9 years later, he's happy, healthy, and well, except for the treatment for the chronic lymphocytic leukemia. But thankfully, that is a disease that can be stable for a long period of time. And he's had no recurrent melanoma. This younger patient came in with a bleeding bump on his back. So here you can see on his back, he has this bump. But when we looked at all of his skin, we noticed he had some other suspicious spots as well, these moles. We call this the ugly duckling sign. So we look at a patient's skin in context. If you look at all of his skin, he has quite sun damaged skin. He has a lot of what we call lentigines, or these sun freckles. He has this sunburn on the back of his neck. And when we took a look at everything, we did some biopsies of the suspicious looking spots, showing that he actually had a moderately dysplastic nevus. So this is a type of a mole that has become atypical. And patients will often ask, well, what makes it look atypical? Actually, under the microscope, there are defined criteria for what a melanoma cell looks like. So if we have a mole that's starting to change in the direction of melanoma, it will start to take on some of the features of melanoma under the microscope as well. Here's a moderately dysplastic nevus. Here's one that's just mildly dysplastic nevus. Here's the spot that was bleeding. It's very pearly, and it turned out to be a basal cell carcinoma. And he even had a melanoma on the back of his neck. So we're really thankful that he came in, that he was willing to have all of his skin checked, that the bleeding bump brought him in, but it actually also helped to save his life because we were able to find this early melanoma, all on the same back. Now, thankfully, when we find a stage 0 melanoma, treatment is simple and cost effective. A straightforward 1-hour office surgery, the patient can drive himself to and from, pathology to evaluate for clear margins under the microscope, and suture removal by the nurse in a couple of weeks with no anesthesia, no plastic surgery or lymph node removal, no imaging, no chemotherapy or radiation. Most of the time, patients with early stage melanoma do extremely well. Unfortunately, there are times when a patient comes in with a later stage melanoma. This 25-year-old student had a long-standing mole on her thigh that grew and became painful. And even though she had a family history of melanoma, she had actually used tanning beds. Biopsy showed this melanoma to be extremely active, with 13 mitoses, or actively dividing tumor cells, every millimeter. And lymph node biopsy showed metastatic melanoma. The patient was started on a systemic medication called interferon, but she was unable to tolerate the flu-like symptoms, mental health side effects, and thyroid changes caused by the chemotherapy, and so the treatment had to be stopped. But then the tumor subsequently spread to her abdomen and lung. Thankfully, we live in an amazing era of immunotherapy to treat advanced melanoma, and after a course of treatment with immunotherapy, which causes the patient's own immune system to find and kick out the tumor cells, the patient's melanoma cleared, and she's now decided to devote her life to helping others through nursing. She's such a lovely person with a bright future, and we're really thankful to have been able to play a small part in her story. And finally, skin cancer doesn't always read the textbook. This 77-year-old gentleman remembers bumping his head on the car door years ago. And when we biopsied this pink nodule with no brown or black coloration whatsoever, it actually looks like a basal cell skin cancer, right? It's pearly and it's got that hot pink color. It's in a sun-exposed area on the top of the head. We found that this actually was an amelanotic melanoma. So there can be melanomas that have no coloration whatsoever. In his case, it had invaded deeply into the skin nerves. And this is why it's so important to pay attention to the behavior of any new or changing or non-healing skin lesion. So here you can see that this ulcerated amelanotic melanoma, ulceration means it's lost the top layer of the skin. So it has this wet appearance because we're looking at the second layer of the skin there with all the tumor cells. Here's another amelanotic melanoma. You actually can see some areas where there's been loss of pigmentation. So there's actually white around the border there. And here again, and you can see that maybe it started its life off as a mole with some pigmentation, because you can see some brown pigmentation around the edge here, and it may have lost it as it continued to evolve into a melanoma. Thankfully for our patient, the lesion was surgically removed with clear margins. The lymph node biopsy was negative, and the patient and his family are looking forward to celebrating the graduation of his granddaughter from Cornell. So in closing, what can we do to prevent skin cancer? Here are our top 10 tips. Number 1, seek the shade, particularly when the sun is high in the sky and your shadow is shorter than you are. Don't turn brown or pink in the sun, because there's no such thing as a healthy tan. Never tan or use a tanning booth. Cover up with long sleeve sun protective clothing and a wide brim hat with a 4-inch brim when outdoors. Use a broad spectrum SPF 15 or higher sunscreen on your face and neck every day. And SPF 30 or higher when you're outdoors. Apply 1 ounce or a shot glass full of sunscreen to all sun exposed areas when outdoors. Studies show that we actually only get the benefit of some of the SPF if we're not using enough, and most people are only using half as much sunscreen as they really should. So the higher the SPF, the better. Keep babies out of the sun for the first 6 months of life. Take a look at your skin. Perform a skin self-exam every month. Be familiar with the moles that you have. That way you're able to find it and bring it to our attention if anything grows or changes. And see your dermatology provider at least once and follow their recommendations regarding how often you would benefit from a full skin check. Now for extra credit, again, we talked about the importance of staying in the shade, especially when the sun is hottest in the sky. So those tend to be between 10 in the morning and 4 in the afternoon. Reapply sunscreen because it won't last all day and it does wash off and sweat off. So you want to reapply it every 1.5 hours whenever you're outdoors, or if you're swimming or sweating, reapply every hour. I recommend that my patients just keep it right next to their toothbrush, their daily sunscreen, so that when they're brushing their teeth, they remember to put on their sunscreen as well. Because just like brushing your teeth every morning, putting on your sunscreen every morning will help you to have better health in the long run. It will decrease your risk of developing skin cancer by 50%. Now, patients nowadays are really savvy. They check the weather on their phone. They check the UV index, which is on the weather report. If you look at this UV index here, it starts off as 0 first thing in the morning when you're brushing your teeth, but it's going to peak. Every day it's going to peak by noon. So you know that that peak is coming. The best way to protect yourself is to proactively have your sunscreen on. That way you're protected all the way up to the peak. And then if you're going to be outside, you can reapply again, get some extra protection. It is a lot of reapplication to reapply every 1.5 hours to all the places of your skin if you're outdoors for an entire day. So if you want to grab some sun protective clothing, that can help because the sun protective clothing does last all day. Often you want to look for the UPF. The clothing may be labeled, for example, with UPF 50. So that's a good indication that it will fully protect you from the sun, protect your skin from turning brown or pink in the sun. In the wintertime, my patients often wonder, do I still need to wear sunscreen? And actually, experts recommend that you have sunscreen on whenever the UV index reaches 3 or higher. So again, if you look at this UV index, in the wintertime, oftentimes by the peak, it will be at 3 or higher. So another reason to have your sunscreen on first thing in the morning. That way you're prepared. And especially be careful around sun, sand, and snow because they can reflect ultraviolet radiation. They actually have done studies with just sunscreen or just a hat. And it turns out the best protection is if you have both, because then you're protected both from the sun coming down, you're also protected from any UV radiation that's bouncing up. All right, so I know that all of this can be very overwhelming, but you guys are here over your lunch. You're very proactive. You're part of this wonderful healthcare consortium. And what I recommend to my patients is just start with one step a day, is all you need to make it to your goal of living a healthy lifestyle overall. If you look at one of the most successful public health campaigns ever, it actually was headlined by this adorable seagull. We're going to have Sid sing his little song for you. So in Australia, where he's from, melanoma is actually known as our national cancer. Let's see what Sid has to say.
Slip, slop, slap, seek and slide, have fun outside, but don't get fried. Slip on a shirt, slop on sunscreen, slap on a hat, seek shade, slide on sunnies, simple as that. Slip, slop, slap, seek and slide, have fun outside, but don't get fried. Slip, slop, slap, seek and slide.
As a result of Sid's song and important message, cases of melanoma in young people in Australia plummeted, falling 5% each year from the mid-1990s to 2010. We can do the same. I'm going to advance to my last slide here. And again, thank you so much for having me here during this Skin Cancer Awareness Month of May. I want to give you all a big pat on the back for being here and being proactive about your skin health. And I also am happy to announce that we have a free skin cancer screening at the shops at Ithaca Mall coming up. So if anyone is available on Friday, June 13th from 4 to 7 p.m., our team will be at the mall for a free skin cancer screening. And this is in partnership with the Cancer Resource Center of the Finger Lakes. So you can find more information on their website, on our Instagram. Everyone is welcome. And I'll share a flyer with the Healthcare Consortium that they can send out to you as well. So thank you so much to everyone for being here today. And I'm happy to take any questions that you have.
Please feel free to raise your hand, unmute and speak, or send any questions in the chat if you'd like. We have been recording, so the recording will go out to anyone that had signed up, whether you were able to attend or not. I guess a question I have for myself is there a preferred type of sunscreen to use for your face, or at your age, you know, is the spray sunscreen better? Is the lotion sunscreen better?
Great question. So there's so many different types of sunscreen out there. So I always encourage my patient, there's the perfect sunscreen out there for you. Some people like less greasy, some people need more moisture. So the most important thing to look for is that it's broad spectrum, because it's important to protect yourself from UVA and UVB. So sunscreens in the past were only protective against UVB, which is the type of ultraviolet radiation that causes skin cancer, but our skin aging is actually from UVA. So we need protection from both. So take a look at the label and make sure it's a broad spectrum sunscreen. The next thing to look for is the SPF. So it's important for an everyday sunscreen to have at least SPF 15, so you can have that base level of protection.
Okay.
When we talk about the face, oftentimes people are they're looking for something that is not so greasy. So you know, there are different formulations that are not as thick. They don't turn you as white. Sorry, Jess, did you have a question or in the middle?
There are a couple of questions that have come in, so whenever you're done.
Perfect. Yep, I'll get right onto those. So finishing up with face sunscreens, for example, there are compact sunscreens, so those don't have any greasiness at all. You apply them with a sponge and it's just powder. And then during different times of year, our skin is going to need different levels of moisture. So in the wintertime, it tends to be very dry. So we recommend that everyone keep your home humidity to 40% if you can, or use a humidifier at night. But during times of year when your skin is more prone to being dry, you may need a layer of moisturizing cream on before you put your sunscreen on. A lot of times people are also wanting to prevent against cosmetic concerns with their daily sunscreen. So for example, I see a lot of patients with brown spots that they don't like. So if you want to not have those brown spots develop over time, it's very helpful to have a tinted sunscreen. So a lot of my patients wear a tinted sunscreen every day that blocks against visible light. Visible light is what causes the brown spots. So yeah, I just love talking about sunscreen. I could talk about it all day. Let's move on to another question.
Okay. Is there a benefit of sunscreen with greater than SPF 30?
Yes, so previously I had mentioned in one of the slides that studies show that we don't apply enough. We don't apply the recommended amount of sunscreen, so we are often not benefiting from the full SPF. There was a head-to-head study done between SPF 50 and SPF 100. Patients that applied SPF 100 had less sun damage. And the reason is that the patients applying SPF 50 and 100, both groups were not applying enough to get the full SPF. So if you get a higher SPF, even if you're not quite applying as much, you're still getting the benefit of that higher SPF and you're more likely to be protected. So if you just remember the shot glass full. That's for a lotion type of sunscreen or a cream type of sunscreen. Now with a spray type of sunscreen, you want to be very aware of the environment in which you're applying it, because if it's windy, a lot of it could be blowing away as you're trying to apply it. So try not to apply it around any wind. You want to make sure not to breathe it in or have it get onto your mucous membranes like your eyes, mouth, or nose. And we always recommend with spray sunscreen to spray 4 times back and forth. So you go back and forth 4 times and you rub it into all the nooks and crannies. And then for your face, spray it into your hand and you can rub it thoroughly into all the nooks and crannies of your face.
Next one, is a face lotion with sunscreen a good choice?
Yes, absolutely. So all you have to do is look at the SPF and whether it's a face lotion or a face compact or a powder, whatever the formulation it comes in, or a spray or a stick. The SPF is, as long as it's 15, it's great for every day. And it's nice to have it as part of your lotion. It's 2 in 1. So that'll make it even more likely that you'll be able to apply it every day.
So, lots of thank yous coming in. Another couple part question. Does clothing need to be labeled UPF to provide protection, or are long sleeves, pants, and a brimmed hat enough? And the follow-up to that, are there particular types of fabric that provide better protection even if they aren't labeled UPF specifically?
Absolutely. So when you look at the UPF, it's based on the type of fabric and also the type of weave. And you can, test this out when you're actually out in the sun and see how much sun is allowed through the clothing. So it all depends on, the specific type of fabric, but there may be, some fabrics that already have very good protection against the sun. And then with the UPF, that kind of makes it a little bit easier for us because it's already been quantified. So we know if it's 50, then it's going to be adequate. And then I would say, as long as you have that layer on, you don't necessarily need more clothing layers, underneath, as long as your top layer has that UPF 50.
All I'm seeing so far for questions. Thank you everyone for attending today's webinar, specific for skin cancer prevention. And thank you especially Dr. McAllister for putting this on with us. And there's a shout out to you and the Dermatology Associates.
Thank you so much, everyone. So great to be here with you all. And if you have any other questions, feel free to send them. I'll be happy to answer them anytime.
All right. Thank you very much.
Have a great summer.
Bye.
Bye.